All right, welcome. This meeting is being recorded. It'll be posted by the OHA in the next couple of weeks. Welcome to the April P&T committee meeting. We do have a quorum as I've counted with the committee members that have joined. Waiting for one more to join, or I'll reach out shortly to see if she's able to join. We got the general announcements on the screen. As Sarah just said, if you're able for the audience to put your full name and your affiliation, that would be useful as we record who's in attendance, so we can put that on the minutes. So we're going to start out with roll call introductions in just a moment, but for those of you in attendance, where you found the link to join this meeting, there is also the posted packet of materials and written testimony that the committee will be considering today. We'll be referring to the pages on that as we move forward. So again, we're going to start off page 3 of the packet of materials, and we're going to do the roll call and introductions. So I'm going to leave it to Pat, if you'll lead off for us.
Everybody, Pat T. Martino, faculty at OHSU, Division of Peds HEMOC.
Welcome. Kat.
Kat Livingston, Medical Director of Health Share, practicing family physician at OHSU.
Welcome, Kat. Stacy is our chair for the year. You voted her in at the February meeting, but she does have some class commitments. So our vice chair is Samara Stevens. She'll be serving as chair today, but Stacy, we'll let you introduce yourself.
Yes, hi everybody and welcome. My name is Stacy Ramirez and I am faculty at OSU College of Pharmacy and the Director of Clinical Services for VitalSync Health.
Welcome. Tim wasn't able to join us today, so Bridget, we'll turn it over to you.
Thanks. My name's Bridget Bradley, and I'm a psychiatric pharmacist at Kaiser.
Welcome, Bridget. And Samara.
Hi, I'm Samara Stevens, and I am a naturopath that works with mental health in private practice in Portland.
Welcome. Jeannie, thank you for being able to join. We'll turn it over to you.
Hello, everybody. Jeannie Savage. I use she, her pronouns, and I'm the Chief Medical Officer for Trillium. And nice to see you all.
Nice to see you too. Thank you. Doug.
I'm Doug Carr, internist by training. I'm medical director at Umpqua Health in Roseburg, Oregon.
Welcome, Doug. Russ.
Hey, I'm Russ Huffman. I use he, him pronouns, and I'm a psychiatric nurse practitioner at Salem Health.
Welcome, Russ. Dr. Onishi wasn't able to join us today, so Eddie, we'll turn it over to you.
Hi, Eddie Saito, clinical pharmacist at Virginia Garcia Memorial Health Center and faculty at Pacific University.
Welcome, Eddie. We'll also do introductions for OHA and Durham staff. Jennifer, if you can lead off.
Yeah, Jennifer Bowen, Executive Support with the Oregon Health Authority.
Roger Citron, Director of the Drug Use Research and Management Program.
Hi, everybody. Trevor Douglas, Director of Pharmacy Policy and Programs at OHA.
Hello, I'm Dave Engen, clinical pharmacist, OSU Durham team.
Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators for the OSU Durham team.
And I'm Andrew Gibler. I'm the clinical pharmacy manager at OHA.
Kyle Hamilton, pharmacy drug coordinator here at OHA.
Dan isn't able to join us, so Megan, your turn.
Hello, I'm Megan Herring, a clinical pharmacist with the Durham team.
Hi, good afternoon. This is Deanna Moretz. I'm the clinical pharmacist with the OSU Durham team.
Hi, I'm Kathy Centena, and I'm also a clinical pharmacist with the OSU Durham team.
Hi, Sarah Servid, co-coordinator with Sarah Fletcher for the Durham group.
Lance Starkweather, pharmacy manager for Gainwell Technologies.
Dee Weston, pharmacy program policy advisor with OHA.
Good afternoon, I'm Brandon Wells. I'm the pharmacy program analyst at Oregon Health Authority.
And Ted Williams will not be joining us. I didn't see Michael join us yet. And Courtney Ho is a PharmD student that's going to be presenting with us later today. So we'll get her introduction once she joins us for her presentation on the oncology policy eval. I'm going to turn my video off. It's quite distracting and I've got multiple screens, so I'm going to take that off. And again, if you're following along in the package of materials, we'll draw your attention to page 4 where we have the minutes. These were sent out, minutes from the February P&T committee meeting. These were sent to the committee in advance. So they had a chance to review. So we'll see if the committee has any edits that they recommend to the minutes. And if not, we would entertain a motion to approve.
This is Jeannie. I motion to.
Second, Doug Carr.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Okay, thank you, everyone.
Samara, rock star. See, you got it handled. All right. Next up, we have the department update, and we're going to turn it over to, I think, Andrew, you're taking the lead today.
Oh, thank you, Roger. We've been busy during our legislative session and a number of other daily activities, but I don't think I have anything to report. I asked Trevor if he had any report outs to the Mental Health Clinical Advisory Group this morning, and he didn't either. I know he's still on, but it needs to go early today. Otherwise, I think I'll yield my time back to the committee that has important work to do today. So thank you, everyone, for your time. And if you have any specific questions about anything, please feel free to raise those now and we can try to answer them.
Any questions for Andrew, Trevor, or the department? All right, hearing none. We'll also have a brief legislative update, and Dee, we'll turn it over to you.
Yes, thank you. I think I'd like to handle this the same sort of way in the interest of time. There hasn't been any major developments since I gave a rundown last time. And so I wanted to provide an opportunity if anybody wants to discuss any legislation that's ongoing in Oregon. Okay. I think that's not. Thank you so much. I know you have a full agenda, so I appreciate your time.
Thank you, Dee. Next, we have the consent agenda. This is a standing placeholder so that we can add drugs to our orphan drug policy, not perform full reviews. We can take that off the agenda if any of the committee members wish to discuss. If not, we'd entertain a motion to approve the consent agenda additions.
So moved.
Thank you, Stacy. Do we have a second?
Second.
Thank you, Pat.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Okay, thank you, everyone.
Fantastic. So again, I'll draw your attention if you're following along in the packet to page 14. We have the drugs for weight management, PA update and obstructive sleep apnea, and we'll turn it over to Kathy Santana.
Great, thanks, Roger. So the purpose of this update is to review the evidence for tirzepatide, the branded Zepbound product, for use in adults with obstructive sleep apnea, or OSA, and obesity, and modify the prior authorization criteria if warranted. In December of 2024, tirzepatide received an additional FDA approval indication for the treatment of moderate to severe OSA in adults with obesity, so a body mass index of 30 kilograms per meter squared or higher. As we know, tirzepatide, the branded Zepbound product, was originally approved back in November of 2023 to reduce excess body weight and maintain weight reduction in adults with obesity or those who are overweight with comorbid conditions. We also know that excess body weight is a risk factor for OSA, so reducing this excess body weight has been associated with improved OSA outcomes. The OSA indication for tirzepatide was based on 2 small phase 3 double-blind randomized controlled trials that both lasted 52 weeks. We're going to look over the evidence on the next slide just briefly. However, if you'd like to see the full evidence tables, those are in your packets on packet on pages 15 and 16. So in both these trials, participants with OSA and obesity that received weekly tirzepatide, 10 milligrams, 15 milligrams, or placebo that was originally initiated at 2.5 milligrams weekly and then increased every 4 weeks. Additionally, the participants had to have a moderate OSA, which is an apnea hypoxia index or an AHI score of 15 or more, or severe OSA, which is a score of 30 or more. Additionally, just for further information, AHI is a number of sleep apnea or hypopneas during an hour of sleep, and the frequency of this was measured by laboratory PSG at the screening week 20 and week 52. Of note, 2 excluded patients included individuals with type 1 or type 2 diabetes, weight changes of more than 5 kilograms in the previous 3 months, or prior surgery for obesity or sleep apnea. So if we look a little bit more specifically at the trials, we can see in the first trial, the patient population was an average age of 47.9 years, a little predominantly male, and a majority were white, with an average BMI of 39.1 kilograms per meter square. Majority of patients also did have severe obstructive sleep apnea with 63%. Additionally, in this trial, these patients were unable or unwilling to use PAP or positive airway pressure. The primary endpoint was change in the AHI score at 52 weeks, and they did find that tirzepatide was superior to placebo with a decrease in 20 events per hour. The second study was very similar. You can see there that the patient population, again, similar to the first trial. However, these patients did have to have or had to be using PAP and continue that throughout the trial. For the primary endpoint, tirzepatide again was superior to placebo with a decrease in 23.8 events per hour. There was additional secondary outcome in which the number of participants with an AHI reduction of 50% or more was higher with tirzepatide versus placebo in both trials, with a number needed to treat of 2. So going to the next slide, just looking briefly at discontinuations, they are similar across all groups and not very high. For safety, most common adverse reaction was gastrointestinal, not surprisingly, with an average serious adverse event rate of around 7.5% across the treatment groups. Limitations to the studies were the small sample sizes, different attrition rates between the groups. Patients all received regular lifestyle counseling, which might not be reproducible in the general population. The study was funded by the manufacturer. We don't have that long-term data that was also very valuable, such as cardiovascular effects. And there's insufficient evidence to recommend tirzepatide for OSA in populations who do not have obesity. So looking at our recommendations, we're going to recommend that tirzepatide be added to the weight management criteria to be covered for OSA patients with obesity. And you can see that there in the third bullet point, we just added OSA, and then as well as kind of reiterating down below that this is just covered for OSA, and then the other tirzepatide product, Mounjaro, is approved for diabetes. This next slide is just kind of a clerical update for setmelanotide, in which the labeling has been updated to be used in patients as young as 2 years and older. Not really. This slide there at the bottom, you can just see that we added tirzepatide to the table to include OSA as an evidence-supported indication. Now, this is the prior authorization criteria that starts at here. You can see at number 14. Numbers 1 through 13 do pertain to other weight loss agents. So since that's not the topic of this update, we're going to go ahead and skip that for now, but of course can revisit that if the committee would like. So as it relates to tirzepatide or Zepbound in number 15, we ask if that's what they're requesting. If so, go to number 19 and just asking if the patient does have obesity, we discussed, as well as a moderate to severe obstructive sleep apnea diagnosis as defined there in the bottom 2 bullet points. And if so, to go ahead and approve it for up to 6 months. And then the next slide looks at the renewal criteria. And this just asks for that it's continuation of therapy in number 1, that the patient's an adult, number 2. In number 4, it's asking, again, that the patient has OSA. So we add that to one of the diagnoses that's covered. If so, we ask that the patient has maintained a BMI reduction of 5% or more, number 5. If yes, then if they've been adherent to therapy as outlined there in number 6, and then lastly in number 7, that the patient's continuing a weight loss treatment plan. And if so, then approve it for 12 months. So the recommendations are to amend the weight management criteria to include tirzepatide for coverage of patients with OSA and obesity, and to evaluate pricing in an executive session. This time I'll take any questions.
Thank you, Kathy. And we do not have any public comments. So any questions?
No
Sorry,
question.
Roger, this is,
Oh, go ahead, Jeannie.
sorry, Doug, this is Jeannie. Quick question. Can you go back one slide to the criteria? I'm confused on the question number 2, 18.
Yeah, so that refers to for other weight loss products as well, but that's for those that are younger than 18. Because
It's
they
the
have,
pathway for EPSDT.
yeah, and they have a little different recommendations in the guideline, which constitutes a significant decrease in body mass index. So that's why for adults, we go from number 2 to number 4.
4.
If they are an adult.
Okay.
Sorry,
Okay.
yeah, should have clarified that a little bit better.
That's okay. And EPSDT is to 21, but the guideline is 18.
Yeah, this is because some of these weight loss medications that we didn't go over in detail in the earlier 1 through number 13 are indicated in younger patients down to 2 years of age. So,
Okay. Okay.
But yeah.
Okay. Got it.
And Doug, did you have a question as well?
More of some comments and observations. This was an excellent approach to looking at the literature and coming down. The criteria for ensuring the criteria for moderate or severe OSA is very important in this group. If you look at the studies, the average AHI is about 50. The treatment reduced it in half on average, leaving them with a moderate to severe OSA. So this is not going to be an appropriate treatment alone. They're going to have to consider, possibly CPAP in addition, a mandibular advanced device or oral pharyngeal surgery or something of that nature. Maybe even hypoglossal nerve stimulation. So it isn't going to, these people, every single one of them still had OSA of a significant degree in spite of the treatment. And what's interesting is that even CPAP has not been shown to reduce, it's been shown to reduce hypertension, but not long-term cardiovascular effects, even though we think, we'd like to believe it. But so this was a great way of approaching it. I commend the group for coming up with this criteria.
Thank you. Yeah, I think those are very helpful comments as well. So thank you.
Any other questions for Kathy?
I have a question about the diet and exercise behavioral strategies. So when I look at, there's question 7 about a weight loss treatment plan, and then question 12. And then I see this box that says recommended behavior strategies, which is what I assume the questions 12 and 7 are referring to. But we have really good evidence that sort of a PCP making recommendations about diet and exercise changes is totally ineffective, and that the things that work are intensive multidisciplinary behavioral interventions. And there's a USPSTF recommendation about that. The diabetes prevention program is an effective evidence-based strategy. And so I guess at a minimum, I would request that those, like the things that we know work, would be something, you know, has this person ever been referred to DPP and have they declined it? I don't want to create like unnecessary barriers, but I guess I'm just concerned that like we know that the only thing that works is intensive lifestyle management. And so at least I would want to call that out.
I think that's a great point, and we have looked at that and how to standardize that and how to monitor for that, because that's so true. And all these treatments were studied in conjunction with these programs, so that is such a integral piece to it. And we at this point have not been able to come up with, you know, a specific program, but we can look into it, you know, further definitely and see what options there are for behavioral interventions that perhaps we could direct them to more specifically.
Yeah, so I would say the diabetes prevention program, which is a CDC approved national DPP program, there are clear standards. It's covered on the prioritized list. So that would be something that I would explicitly recommend.
Okay, thank you.
And I can put a link. I put a link to the evidence review that informed the USPSTF. They're actively updating their current recommendation, but the recommendation is to refer to multi-component behavioral interventions, again, because like 26 hours a year is kind of the minimum necessary to make changes. And then the DPP I can put in there as well.
And are those requirements that you currently have in your own CCTO, Kat? And again,
no, I'm just speaking to like what the
no, I
evidence
appreciate
has
just
actually
looking
works.
one kind of poking at access, and again, you're kind of in more of an urban setting, but really appreciate your comments.
And OHA has led a lot of initiatives to try and increase diabetes prevention program in our state. So it does align with other efforts, but there are a lot of barriers.
Absolutely. Jeannie?
Yeah, I think that's exactly where I wanted to go, because while I agree that, Kat, exactly with everything that you said, there's pretty significant barriers for a percent of the population. I would say a significant group of the population in doing that. I mean, if you're working at all and trying to get to some of those programs, it's really difficult. And if you're an area outside of where they're offered, typically in a rural setting, it's really difficult to get to them as well. I mean, more available now with telehealth, yes, but are they as effective? I don't know. I'm not sure about that. So yes, hopefully. I just think that the barrier to getting that and to having the ability to commit to that is pretty significant. And I'm not sure that putting it as and I don't think you're suggesting to putting it as a criteria. I think you're suggesting to make it a recommendation. Makes sense. I just I can see the discussion being, it's just more barrier to get to a effective way of treating something. Right? And hear people just say, you're just putting up more barriers. I can't do that. I'm working. How do I can't get that program available. I just want to start something that'll start working now and hopefully do something with that program as well eventually. But I keep hearing that from people in the community more than.
Great comments. And the more we can put education around this piece too, as one, we have coverage for some of these other comorbidities with these medications, and then look to the future, perhaps more coverage, education around the other modalities that are going to increase the likelihood of success is really important. Other comments? Okay, so the recommendation in front of the committee is to amend the weight management drug PA criteria to allow the coverage of tirzepatide for patients with OSA and obesity. And then we're also planning to review pricing in executive session.
I move
there's
for
no more dis-
approval, Doug Carr.
Thank you, Doug.
Second, this is Russ.
All those,
Thank you, Russ.
all those in favor?
Aye.
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 Anyone opposed? Abstain? Okay, thank you, everybody.
Great, thank you. Next topic starts on page 26 in the packet of materials. New drug evaluation, and we'll turn it over to Megan.
Thank you, Roger. So this is the new drug evaluation for aprocitentan or Trivio. And the purpose of this was just to evaluate the evidence about this new drug. A little bit of background, this medication is indicated for resistant hypertension. Resistant hypertension is defined as hypertension despite the concomitant use of 3 antihypertensive drugs of different classes, including a diuretic. This is relatively common. Resistant hypertension occurs in about 10 to 15% of adults with hypertension, and medication non-adherence is as high as about 30% in resistant hypertension. And patients with resistant hypertension are a particularly high cardiovascular risk and tend to have additional cardiovascular risk factors. Current guideline recommended standard of care, it usually consists of a combination of 3 medications, including an angiotensin converting enzyme inhibitor or angiotensin receptor blocker, a calcium channel blocker, and a thiazide diuretic. There is limited randomized controlled trials evaluating 4th-line medications, but data does support 4th-line medication being a mineralocorticoid receptor antagonist. And there is no evidence evaluating clinically relevant cardiovascular outcomes for 4th-line medications in resistant hypertension. So aprocitentan is an endothelin receptor antagonist that inhibits the binding of endothelin-1 to ETA and ETB receptors. It has a higher affinity for ETB receptors, which is different than the other endothelin receptor antagonists that are used and indicated for pulmonary arterial hypertension. Through this, it does decrease endothelial dysfunction, vascular hypertrophy, remodeling, sympathetic activation, and aldosterone synthesis. It is FDA approved only at the 12.5 milligram dose. We'll see it was also studied at a 25 milligram dose, but it's FDA approved at 12.5 milligrams for the treatment of resistant hypertension in combination with other antihypertensives. And as I mentioned, other medications in this class are only indicated for pulmonary arterial hypertension. Some have been studied in hypertension with conflicting data, as well as limited by high rates of side effects, mainly fluid retention or edema. Next slide. So aprocitentan was FDA approved based on 1 phase 3 multi-center partly blinded randomized controlled trial, the Precision trial. Eligible patients had to have resistant hypertension despite taking at least 3 medications for at least 1 year. And after the initial screening, all subjects switched their home regimens to a standardized background therapy, which was a single pill combination drug, including amlodipine, valsartan, and hydrochlorothiazide at fixed doses. Those who still had uncontrolled blood pressure after the screening and run-in periods were then randomized to aprocitentan 12.5 milligrams, 25 milligrams, or placebo. The mean age was 63, 60% were men, and 83% were white. The primary endpoint was change in systolic blood pressure from baseline at week 4, which was measured by unattended automated office blood pressure. And you can see down in the results, the mean change in systolic blood pressure was 15.3 millimeters of mercury with the 12.5 milligrams dose, and then 15.2 with the 25 milligram dose. And this resulted in a pretty small mean difference from placebo of 3.8 with the 12.5 milligram dose and 3.7 with the 25 milligram dose. And this kind of small difference was due to the kind of high effect with placebo. Placebo resulted in a lowering of systolic blood pressure of 11.5 millimeters mercury. Next slide. This is just a figure that shows kind of the complex study design. Again, there was the initial screening where everyone was switched to standardized background therapy. And then only those who still had uncontrolled blood pressure, as well as who had at least 80% of adherence to the standardized background therapy, were randomized to treatment. And this was the only double-blind kind of 4-week period. There was some further treatment, single-blind treatment period with over 32 weeks. This was only with the 25 milligram dose, which was not FDA approved, and then another double-blind re-randomization withdrawal period, which was a secondary outcome of the study. Next slide. In terms of safety of the medication, there were low rates of serious adverse events overall, and as well as rates of discontinuations due to adverse events, which were about 2% with the 12.5 milligram dose compared to less than 1% with placebo. Adverse effects of a concern, again, include fluid retention and anemia, which did occur more frequently with aprocitentan than placebo. While there wasn't kind of a dose-related effect in its blood pressure lowering ability, there was in side effects. So fluid retention-related side effects occurred in 9% of those on the 12.5 milligram dose, but in 18% of the 25 milligram dose, which is why that higher dose was not FDA approved. And then anemia occurred in 4% of the aprocitentan 12.5 milligram group, which was more than placebo. Furthermore, aprocitentan is contraindicated during pregnancy because of a known risk of teratogenicity. Women of childbearing potential were only eligible for the study if they had a negative pregnancy test, agreed to take pregnancy tests during the study, and agreed to use accepted methods of birth control. Next slide. So aprocitentan does offer another treatment option for kind of a narrow population of those with resistant hypertension who have few other add-on medications available that are data supported. However, there are several limitations to consider because of the complex study design, which was designed to include only those with true resistant hypertension. And to show a sustained blood pressure effect. There was attrition at kind of multiple steps of that process. And the FDA approved 12.5 milligram dose was not studied, but beyond that first 4 weeks of the study. The 2 fixed doses of background therapy were not at max dose of valsartan and did not include a long-acting diuretic such as chlorthalidone. And furthermore, only about 70% of subjects were on maximum dose of amlodipine. As discussed, there was no clear dose response and efficacy, but there was an increase in edema-related side effects with the higher 25 milligram dose. And in the US, the prevalence of hypertension is higher among Black adults. However, only 11% of subjects in this study were Black or African American. And lastly, there was no, the study was not designed to measure cardiovascular outcomes. So in conclusion, there was low quality evidence that aprocitentan 12.5 milligrams once daily lowers systolic blood pressure more than placebo with a change from baseline of 15.3, and in adults with resistant hypertension on at least 3 antihypertensive medications. There's insufficient evidence comparing aprocitentan to other medications, including mineralocorticoid receptor antagonists, and insufficient evidence on clinically important cardiovascular outcomes. And side effects of concern include fluid retention and edema. Many of the patients required kind of management of this side effect with optimization of diuretic therapy. Next slide. Our recommendations are to maintain aprocitentan as non-preferred on the preferred drug list and to implement proposed PA criteria to ensure appropriate use. I think the PA criteria is on page 34 of your packet, and you can see it here in the slides. We are asking in number 2 of the criteria that they have resistant hypertension, and 3, that they are on maximally tolerated doses of either an ACE or an ARB, as well as a calcium channel blocker and a thiazide or thiazide-like diuretic. And then in question 4, asking that the patient is either taking a mineralocorticoid receptor antagonist, has had an inadequate treatment response to a mineralocorticoid receptor antagonist, or has an intolerance or contraindication to an MRA. And with that, I will take any questions.
Good job, Megan. Any questions for Megan on the presentation or proposed criteria? And we do have one person signed up for public comment. Questions? All right. From Idorsia Pharmaceuticals, we have a representative, Sajani Bharat. I hope I didn't say your name too incorrectly. Are you able to unmute your line?
Yes, I can. Thank you.
I can hear it just lightly. Can you speak up a little bit?
Yeah. Can you hear me now?
There we go. I think we've got you. So the floor is yours. I'm going to start a timer, and you have 3 minutes to address the committee.
Okay, thank you very much for the time today. My name is Sajani Bharat. I'm a field medical liaison for Idorsia Pharmaceuticals. I'm here to provide testimony on Tryvio, which is a recently approved medication for high blood pressure. It is approved for use in combination with other medicines to lower blood pressure in adults who do not have their blood pressure under adequate control. First, let me remind this committee on the impact of high blood pressure in our population. In fact, 1 in 3 adults who are enrolled in Medicaid have hypertension, which costs the U.S. about $131 billion each year. Furthermore, having hypertension puts a person at risk for heart disease and stroke, which are leading causes of death in the U.S. The treatment of hypertension involves the progressive addition of diverse types of medication from different drug classes, as they can have complementary and incremental effects to lower our blood pressure. However, often this is not enough, as evidenced by the fact that approximately 60% of patients who are on multiple medicines still have blood pressure values that are above the recommended guidelines. One metabolic pathway that is key to the development of hypertension is the endothelin pathway. And until the approval of Tryvio by the FDA last year, there had not been a medication for systemic hypertension that addressed this important mechanism. Tryvio is the first and only dual endothelin receptor antagonist for this condition. Tryvio was specifically designed with a long half-life of 41 hours, which allows for once-a-day dosing. It can also be prescribed for hypertension in patients with poor kidney function, and it has been studied in patients with GFR values as low as 15. The pivotal clinical trial, Precision, looked at patients who had fully verified resistant hypertension. And in this trial, 730 adults were randomized to take either aprocitentan or placebo in addition to standard background triple therapy. The treatments were evaluated for both for the immediate effect after 4 weeks, as well as for longer term at 40 weeks versus placebo. We used both in-office and 24-hour ambulatory blood pressure monitoring in this trial. Tryvio demonstrated a statistically significant and clinically meaningful blood pressure reduction at 4 weeks of 15.3 millimeter mercury with addition of Tryvio, compared to a reduction of 11.5 with the addition of placebo. Furthermore, at 40 weeks after randomization, the aprocitentan 25 milligram dose had a 19.2 to 19.3 millimeter mercury lower systolic blood pressure compared to baseline. Blood pressure lowering results were consistent among all subgroups, and in addition to the lowering of blood pressure, Tryvio did lead to a 48% reduction in UACR versus placebo in those patients who had proteinuria at baseline. Tryvio was generally well tolerated, and the adverse events reported in more than 2% were edema and anemia, which were mild to moderate and manageable in most patients and readily reversed after drug discontinuation. Just to update the group here, that REMS has been removed for Tryvio as of 2 weeks ago, and this was something that is hot off the press. So Tryvio no longer has a REMS program, and the company is working to change some of those things on our website, along with how we distribute the drug. Thank you for your time and consideration. I'll be happy to take some questions.
Thank you. Any questions from the committee? Okay, thank you for your time. So again, the recommendations are to maintain Trevio as non-preferred and to implement the proposed PA criteria. Any discussion? All right, hearing none, do we have a motion to approve those recommendations?
Motion to approve, Doug Carr.
Second, Eddie.
All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? Okay, thank you all.
Great, thank you. All right. Next up, Courtney, I know you just joined, so we're going to put you on the spot. This is how we're rolling right along. So if you're following along in the packet of materials posted to our website, those can be found starting on page 36. And Courtney, if you want to give a brief introduction since you weren't here at the start of the meeting, and then we'll let you take off with your evaluation.
Okay, well, hello everyone. My name is Courtney. I am a fourth-year pharmacy student at Oregon State University. And today I'll be going over the anti-neoplastic policy evaluation. To give a bit of some background, Oregon Medicaid implemented a prior authorization policy in 2020 for anti-neoplastic agents. And the purpose of this was to ensure that the use of medications allowed for clinical benefit, manage costs to ensure that resources are being used to benefit the greatest number of patients, and also to avoid experimental uses of medications that have limited evidence in therapy. This policy evaluation aims to assess the utilization trends in newer anti-neoplastic agents, which are defined as agents that were approved by the FDA after 2008. And we also wanted to see the impact of the prior authorization criteria that was put in place. So going off of that, the current policy in place requires PA for newer anti-neoplastic agents, as well as documentation of a funded condition that is also FDA approved or guideline recommended therapy. The questions that we explored for this policy evaluation was targeted towards the impact of the PA implementation. So this included reviewing the drug classes that was used, as well as changes in utilization trends, such as proportion of paid and denied claims, as well as the cost over time. In terms of methods, the study is a retrospective descriptive analysis. The patient's demographics, diagnosis, drug classes, as well as the denied claims, they were analyzed and compared amongst two cohorts. The pre-policy cohort is between the time frame of October 1st, 2017 to September 30th, 2020. And the post-policy cohort was between the time frame of January 21st, 2021 and December 30th, 2023. Any members that had denied claims during the post-policy timeframe had their chart reviewed to determine why. In terms of our inclusion criteria, these were claims that have been paid for or denied by Medicaid fee-for-service for these anti-neoplastic agents during the drug evaluation window that was mentioned previously. The exclusion criteria includes cases where fee-for-service was not the primary payer, or if the member had an index event in both of the evaluation windows. Moving on to the results. So this figure here illustrates the cost per member per month for both the newer and older anti-neoplastic agents from 2017 to 2023. The overall amount paid per member remained relatively consistent for both newer and older anti-neoplastics following the PA implementation. And we see that there is like an intense peak. There are intense peaks for the newer agents, which is the one in the blue lines, while the red line remained more consistent. In the next slide, I will provide a deeper breakdown of like the costs. So this table demonstrates the total cost for newer anti-neoplastic agents, and we see that they have increased annually since 2017. We also see that there's an increase in the number of utilizing members along with the claim count as well. Conversely, the total drug cost and claim count for older anti-neoplastic agents have decreased from the same time frame. We see that while the total drug costs have gone up for newer neoplastic agents, the claim count has also gone up. So as a result, the cost per claim has remained similar in 2023 compared to what it was in 2019. So this table here represents the demographic characteristics of the members utilizing anti-neoplastic agents. After the exclusion criteria was placed, we see that there was a total of 27 members with a claim for newer anti-neoplastic agents prior to the PA implementation, and there were 37 members after the PA implementation. We see that the number of fee-for-service members with a claim for older anti-neoplastic agents decreased from 358 to 273. The average age of members receiving anti-neoplastic agents were similar amongst both periods, about 50 years of age. And more importantly, we see that with the new start of newer anti-neoplastic agents, a lot of these had no prior treatment, and originally it was 90% in the pre-implementation group, and then in the post-implementation group, we see that 100% of the requests were for new starts. Newer anti-neoplastic agents were often prescribed by oncology or hematology providers more frequently compared to older anti-neoplastic agents, as well as less than half of the newer anti-neoplastic agents were pharmacy claims, while the majority of them were medical claims. Here we have the common cancer diagnosis and how our study population fits into that. We see that leukemia is the most common cancer diagnosis during the pre-implementation timeframe for those that are using these newer anti-neoplastic agents. And lung cancer was the most common diagnosis during the post-implementation timeframe with the use of newer anti-neoplastic agents. Breast cancer and prostate cancer had similar rates of usage with newer anti-neoplastic agents, and they were the second most common cancer during the post-implementation timeframe. And then in terms of drug class, most newer anti-neoplastics were utilized by members, were indicated for solid organ tumors. The most prescribed ones in both the pre and post-implementation groups were for monoclonal antibodies as well as kinase inhibitors. And this table only shows the newer agents, but just for completion purposes, the most frequently prescribed anti-neoplastics, the older ones, were for antimetabolites and aromatase inhibitors. The overall prescribing patterns of anti-neoplastic agents didn't have a large change due to the policy update. So consistent with our goals of the PA policy, the newer anti-neoplastic agents were all FDA approved as well as NCCN supported indications. And we did see that 37 of the 37 newer anti-neoplastic prescribed in the post-PA group, 20 of them were FDA approved through the accelerated approval pathway, and 4 of these indications were later on taken off from the market. So this table goes over the proportion of people with paid or denied claims for older and newer anti-neoplastic drugs. So following the PA implementation in 2020, proportion of new start treatments with paid index events decreased from 99.7% to 88.9%. The newer anti-neoplastic drugs Of them, 14 members had an initial denied claims. A chart review was performed for these claims, and we saw that of the 14 denied claims, 12 of them had subsequent paid claims for newer anti-neoplastic agents within 90 days. And additionally, most of these claims were actually for the original agent that they requested for. And a lot of them had their subsequent paid claims within 30 days. So moving on to the limitations of our study, our sample size was on the smaller end of the scale with about 37 members, which comprised of 7.3% of the total members. Specifically, this is 7.3% before applying all the exclusions. This definitely led to a reduced generalizability of our analysis. Additionally, there were missing data within the internal PA test, specifically for the diagnosis of specific cancer. So this prevented accurate determination of the primary cancer diagnosis and identification of if there were use of other agents before requesting these newer agents. So it made it a little bit more difficult to see if the agents that were requested were NCCN guideline recommended therapies for these specific cancer diagnoses. In terms of conclusion, we see that the majority of prescription claims were still for older anti-neoplastic agents. However, newer agents represent a higher total cost for fee-for-service Medicaid. Newer anti-neoplastic agents that were prescribed were all FDA approved and NCCN supported indications. And overall, the implementation of the PA criteria resulted in few delays in therapy. However, we do see an increase in utilization and cost of newer anti-neoplastic agents, but this may also be the result of generally more members utilizing these agents, and if people are using them for for a longer duration of time. There definitely is opportunity in the future for investigation of evidence-based step therapy protocols supported by current clinical guidelines. As of our recommendations, we recommend to continue with the PA in place for these newer anti-neoplastic medications due to the high costs of medications, ongoing accelerated approvals, and especially since there was not evidence of a barrier in access or delay in therapy from the PA policy. We also recommend to update prior authorization criteria to include any new or recently approved anti-neoplastic drugs. And we encourage cost-effective evidence-based step therapy for certain cancer indications supported by clinical guidelines. And then here I also included the PA criteria that was implemented. So here, anything that's not in Black words has been updated or there's been some change made. So we see that in the blue words with the red boxes around, we added that in. We also, in step 1, we can see that we want to document what the diagnosis is for the patient and to evaluate if there's any oncology emergency. And then we also want to document if this is a continuation of treatment, if it's funded by OHP, how severe is the condition, and the review of the drug that's requested to see if it's FDA approved and if it's supported by the NCCN guidelines. And then here in the red box is our updated suggestion. We want to review if there's any equally or higher recommended alternative based off of the guidelines for the requested indication to further evaluate if there's proper use of the anti-neoplastic agent. And I think there was one slide before that for the P&T committee discussion, if you guys have any questions or would like to discuss more.
Great job, Courtney.
Thank you.
the committee. Do you have any questions for Courtney on the data and the information she presented?
I'll just chime in to say that was great. And yeah, I think the PA criteria look great.
I agree. I think that, you know, it's previously it seemed like more of a rubber stamp, and now there's a little bit of some potential discernment. You know, NCCN guidelines generally are very liberal, very generous. They are created by you know, the specialty group with that in mind, and so we're not using those aren't very restrictive, but when we have practitioners who are requesting and it's not even supported there, it represents a big reach.
Appreciate that, Doug. Other comments or questions? Appreciate your support, Pat. All right, so the recommendations are on the screen in front of the committee. Continue the PA for these newer anti-neoplastics. We're going to update the criteria as proposed. Saw that on the screen. And also to encourage cost-effective evidence-based step therapy for certain cancers when those are supported by the clinical guidelines. We entertain a motion.
I'll motion.
Thank you, Pat.
Second, Doug Carr.
Thank you, Doug. All those in favor?
Aye.
Aye.
Hey,
Anyone opposed? Abstain? Okay, thank you all.
Great. Again, Courtney, really nice work. Next, we're going to turn your attention to page 61 if they're following on the packet of materials for the non-injectable anti-epileptic class update. And Deanna, we're going to turn it over to you.
Thanks, Roger. So this is specifically focused on the non-injectable anti-epileptics. And if we could go to the next slide. The purpose is to look at any recently published evidence for the AED class. The last time we looked at this class for seizures was in 2022, October 2022, when there was a new drug that was released. And then in June of 2024, we reviewed off-label uses of gabapentinoids, and we modified the PA criteria to allow use of gabapentin for generalized anxiety disorder in people that have tried or failed a SSRI or SNRI. The other reason we wanted to look at this was to establish medical necessity criteria for the use of AEDs in fibromyalgia, which is currently unfunded by HERC, but when the benefit plan update is retired in 2027, it will become a funded diagnosis. Next slide, please. So if you look at table 1 on page 66 of the packet, I've identified all the specific diagnoses. This class of drugs covers a wide variety as evidenced in this slide. I do want to point out on page 66 of the packet, there's some discussion about the compendial use of clobazam in some of the drug-resistant seizure disorders. Specifically, clobazam is approved to use in Lennox-Gastaut, but it's also been used off-label in Dravet syndrome. And that's important because it's part of our recommendations that I'll get into in a little bit. But you can see not only are the AEDs used for seizures, but they're also used for a lot of pain conditions like neuropathic pain associated with diabetes or post-herpetic. And then also we've got some migraine prevention and trigeminal use of some of the specific anti-epileptics, and also bipolar disorder. Next slide, please. So there was quite a bit of evidence from the last 2 years. We have 4 high-quality systematic reviews, and there was 5 clinical guidelines. So we'll take these in 2 separate categories. We'll talk about use in pain management first, and then we'll move into use of the seizures. So if we could go to the next slide, please. So the Drug Evidence Review Commission did a rapid review of treatment alternatives for opioids in chronic pain syndromes. That was published in 2023. And most of the evidence focused on evaluating the guidelines that are out there. So they identified 4 clinical practice guidelines that specifically recommend using anti-epileptic drugs for managing pain. So the first is the American Academy of Neurology, which recommends using gabapentinoids for diabetic peripheral neuropathy. And they also recommend valproic acid as a third-line treatment for adults with diabetic peripheral neuropathy. It's a third-line recommendation because there are a lot of risks associated with using valproic acid, specifically in pregnancy. And then in 2022, the VA came out with some guidance for use of the gabapentinoids in low back pain with or without radicular symptoms. And the evidence is low quality, but the VA does recommend gabapentin or pregabalin for people that have low back pain. Next slide, please. Thanks, Sarah. So 2 other guidelines that the DERP review looked at was the National Institute for Health and Care Excellence in 2020. They came out with some guidance about using the gabapentinoids in chronic neuropathic pain. And then they also recommend, based on expert opinion, to use carbamazepine as initial treatment for trigeminal neuralgia. The SIGN guidance from Scotland, they have some guidance for neuropathy as well, and they recommend using gabapentin basically for the FDA-approved indications. And then you can see that pregabalin is recommended for fibromyalgia based on high-quality evidence. Pregabalin is FDA-approved for fibromyalgia. And they also recommend using pregabalin for neuropathic pain if the first-line agents, either amitriptyline or gabapentin, do not work. And then finally, they have a recommendation about using carbamazepine for neuropathic pain as long as the adverse effects are discussed with the patient. Next slide, please. There was a good systematic review in 2023 that basically looked at the safety of gabapentinoids in managing neuropathic pain. And most of the adverse effects with gabapentinoids, it pertains to either the nervous system or psychiatric disorders. So the second bullet there lists the risks with pregabalin, and they're listed in order of decreasing frequency. So incoordination, abnormal gait, ataxia, euphoria, those are the most common adverse effects with pregabalin, and that's one of the reasons that it's considered a controlled substance is because of some of these euphoric effects that are observed in people that take this medication. And you'll see weight gain was the last, where conversely, when they looked at the adverse events associated with gabapentin, weight gain was first, followed by dizziness, peripheral edema, and somnolence. Next slide, please. So in 2021, the European Academy of Neurology came out with some guidance for trigeminal neuralgia. And so they recommend carbamazepine and oxcarbazepine. And if you remember, oxcarbazepine is a prodrug for carbamazepine. And those are both recommended for long-term treatment of trigeminal neuralgia. They did come out with some recommendations that were based on low-quality evidence that lamotrigine or gabapentin can also be used for trigeminal neuralgia. Next slide, please. There was some additional VA guidance that came out in 2023 about migraine headache prophylaxis. And so the VA does recommend topiramate. All of these are weak recommendations for headache prophylaxis, but they do recommend topiramate, valproate. They do not recommend gabapentin. And there's insufficient evidence for levetiracetam, which is Keppra, for preventing episodic migraine. Then the International Headache Society came out with some additional guidance in 2024, and they recommend that valproate may be used particularly in patients that have comorbid conditions such as epilepsy, mania, anxiety, and depression. There's some reasons you may want to use topiramate, particularly in patients that have epilepsy, obesity, mania, anxiety, essential tremor, or alcohol dependence. However, valproate does have cautions in people that have hepatic disease, if they have bleeding disorders, obesity, or, as I mentioned previously, people of childbearing potential. And additionally, topiramate should be avoided in people that have renal impairment, glaucoma, depression, cognitive concerns, and again, if they're people of childbearing potential. The International Headache Society guidance did have some recommendations for treating migraines in children and adolescents, which they recommend using beta blockers at doses adapted to the body weight. Although we don't have great evidence in pediatric patients. And then they went on to say that if the beta blockers don't work, then maybe low-dose topiramate or amitriptyline are possible alternatives. And just as a reminder, topiramate is FDA approved for migraine prevention in children that are aged 12 years and older. So switching gears and moving into guidance for management of seizures. There was a systematic review in 2023 that looked at the safety of cannabidiol in patients with epilepsy. And basically, the only evidence they had was compared to placebo. So the most common adverse effects with cannabidiol compared to placebo were somnolence, decreased appetite, and fever. And not surprisingly, compared with the placebo group, the cannabidiol group did have a higher risk for occurrence of serious adverse effects that result in stopping the drug or reducing the dose. Next slide, please. There was some great guidance from the American Academy of Neurology, the American Epilepsy Society, and the Society for Maternal and Fetal Medicine that talk about what are the safety risks in people of childbearing age that have epilepsy. So they came out with some recommendations, and if someone is already pregnant, they recommend being careful if they have tonic-clonic seizures in withdrawing the medication during pregnancy. And the ones that they found that have the lower risk of adverse effects on the fetus were lamotrigine, levetiracetam, or oxcarbazepine. And then, again, they reinforced that avoiding the use of valproic acid in people with epilepsy of childbearing potential to minimize the risk of congenital malformations, poor neurodevelopmental outcomes, and lower IQ. And then the last bullet there, they also reiterate avoiding valproic acid or topiramate to minimize the risk of the child being born small for their gestational age. Next slide, please. So the Cochrane review did a nice systematic review of the use of lamotrigine in bipolar disorder in 2021. And again, most of the evidence was compared to placebo. They did have some that was compared to lithium. When compared to placebo, lamotrigine did reduce the risk for recurrence of manic symptoms. And the same thing they saw in terms of the risk of clinical worsening. Lamotrigine was favored over placebo. And then they did have some studies that looked at lamotrigine versus lithium, and they noticed that there was similar efficacy between the two groups, except the recurrence of manic symptoms seemed to be more common in the people that received lamotrigine versus lithium. And then when they looked at adverse effects, it seemed that less people had adverse effects with lamotrigine compared to lithium. And MCAG came out with guidance in 2019 about using the AEDs in bipolar disorder. And they specifically recommend 2 AEDs, which I've bolded on this slide because there are other drugs we can use for bipolar, including the antipsychotics and lithium. So specifically for bipolar depression, first-line medications include lamotrigine, lithium, and quetiapine. And if you look at the PDL, lamotrigine is considered voluntary because it is used in mental health conditions, and the same with divalproex, it's also considered voluntary. It's recommended as second-line monotherapy for bipolar depression, along with the other two antipsychotics that are listed there. Then if combination therapy is needed to treat bipolar depression, lamotrigine or divalproex are recommended in combination with other agents. When treating acute bipolar mania, MCAG recommends first-line combination therapy with either quetiapine or lithium or quetiapine and divalproex, along with psychosocial treatment. And then finally, lamotrigine should not be used if patients only need treatment for acute mania. So that wraps up all of the systematic reviews and clinical guidelines. In the few short years since we've looked at these drugs, we do have some expanded indications, and those are listed there. So basically the expanded indications, I won't go through all of them, just approved use in pediatric patients, either down to 2 years or 1 month of age. And prior to that, they were approved in pediatrics, but maybe it was 4 years of age or 2 years, depending on the drug. I will point out at the very bottom of the slide, there is a new formulation of lacosamide. It's an extended release capsule, and it's approved for partial onset seizures and tonic-clonic seizures in adults and pediatric patients that weigh at least 50 kilos. And then vigabatrin came out with a branded concentrated oral solution, which has FDA approval for use as monotherapy. I can't talk today. Monotherapy treatment of infantile spasms in infants 1 month to 2 years of age. There are risks of vision loss with vigabatrin, so the risks versus benefits should be evaluated in that case. So now we'll get into the recommendations. As I mentioned earlier, based on the compendial support for clobazam to be used in treatment-resistant seizures, we would like to retire the clobazam PA criteria and make at least one formulation of clobazam preferred, which we will evaluate in executive session. And then also we would like to revise the pregabalin PA criteria to include medically appropriate use for fibromyalgia in patients that currently have the EPSDT benefit. And as I mentioned, we'll look at the costs in exec session. So we'll go through the changes in the pregabalin PA criteria real quickly. We didn't revise any of the other AED PA criteria, so I'm not going to go through those. Basically, what we did here was take out the word funded under the goals in anticipation of those changes in 2027. So basically provide coverage only for diagnoses that are supported by the medical literature. And if you want to look at the PA criteria, it starts on page 100 of the packet. And then on the next slide, instead of saying pregabalin formulations that have funded indications, we left the funded lines in there for now. We will take that out in 2027, but we changed the title to state that it's pregabalin formulations for FDA-approved indications. So you'll see that pregabalin is approved for quite a number of neuropathic conditions. The extended release formulation is only approved for diabetic neuropathy and postherpetic neuropathy. Next slide, please. So the biggest change to the PA criteria was to add question 9 to assess if they were using short or long-acting opioids, basically because there's insufficient evidence to support use of opioid products in neuropathic pain conditions. And then we also wanted to look at, are they using non-pharmacologic recommendations? And if you refer to table 3 in the packet, I think that's on page 71, when DERP looked at some of the guidelines, they did have non-pharmacologic recommendations for almost all of those neuropathic conditions. So we included that as another assessment. So the suggestions for non-pharmacologic treatment are acupuncture, supervised exercise therapy, yoga, and meditative movement, depending on what the condition is. And then finally, we revised question 11 to talk about has the patient tried or failed, or do they have intolerance to a preferred gabapentinoid. So right now, the only preferred gabapentinoid we have is gabapentin, but in exec session, we would like to talk about maybe making one of the pregabalin formulations preferred to offer the opportunity for coverage for folks that have the EPSDT benefit. Next slide, please. I think that's all I've got. So are there any questions from the P&T committee?
Great job, Deanna. Kat.
I have a question about the benefit update project and the table that has fibromyalgia being unfunded. So, and there's no current criteria. So what is the plan in terms of the BUT project and unfunded conditions and pregabalin?
We talked about this at the last P&T meeting, and I think you weren't here, so you may have missed that. So if you go to the HERC webpage, there is a lot of, there's a FAQ about the benefit update project. And basically in 2027, based on federal guidance, Oregon will be retiring the prioritized list. So a lot of the topics that we're bringing forward this year and next are in an effort to make us a little bit more nimble so that when 2027 arrives, we're not trying to go through all of the criteria that mentioned funding. Roger, do you have anything to add?
No, I think that's accurate. So again, the prioritized list will be there, but the funding line, as you know, Kat's been doing some work too on the HERC side of the equation with the benefit update project. But for this, it's providing a pathway for EPSDT. So for things that aren't currently Medicaid and aren't subject to the prioritized list funding line. So that's what we're doing with developing the criteria specifically. And then that will be able to transition into broader coverage come 2027. Does that answer your question?
No, sorry.
Okay.
You want to go back to that page of the criteria? Would that be helpful?
Yeah. So in 2027, if somebody has fibromyalgia, where do they fall on this? Because it looks like they're still funded. You know, 5 still has is the request for a diagnosis funded by OHB. So when presumably that will go away by 2027, and then will the limitations around pregabalin for fibromyalgia just be all of the, like, I just want to understand like how that would work when line 5 will get changed at some point.
Yeah, can I jump in here?
That would be great. Thank you.
Yeah, so the goal here is to propose criteria that we could ultimately adopt, assuming there aren't any major changes in the evidence in the next 2 years, when we remove this question 5 from the criteria. So the criteria that we're sharing in front of you now is what we would ultimately adopt when we can no longer deny things based on funding. So when fibromyalgia is funded, you would go through these questions and ask, are they on a concurrent opioid? Are you doing non-pharmacologic treatment? Have you failed a preferred product? And that would become our medical necessity and appropriateness criteria. Does that make sense?
I don't know if you're going for your mute button or off camera, so we'll take it as that makes sense. So thank you, Sarah, for stepping in.
I appreciate that.
So again, if we go to the recommendations, any other questions from the committee for Deanna? We do have, apologize, before we go right to the recommendations, we do have 2 people that have signed up to provide public comment. So let's start there. Amanda Rendall from Norellis, manufacturer of Valtalco. Are you able to unmute your line?
Yes, can you hear me?
Can hear you loud and clear.
Great.
And with that, the floor is yours.
Okay, so my name is Amanda Rendall, and I am a Senior Medical Science Liaison in the Department of Clinical Development and Medical Affairs Affairs at Neurelis. We request that Valtoco remain in a preferred position without restrictions. I'd like to give my time back to the committee, but I'll remain on the line to answer any questions you may have. Thank you.
Well, that was short and sweet. You didn't give me time to toggle the BIMs. Any questions in regards to Valtoco from the committee? Okay. The next we have Pam Eads from UCB, manufacturer with Fintepla. Are you able to unmute your line?
I am, yes, thank you very much.
The floor is yours.
Okay, great, thank you. Good afternoon, my name is Pam Eads and I am the Medical Outcomes Liaison for UCB. And I'm here to discuss two rare forms of epilepsy and UCB's product Fintepla. Dravet syndrome and Lennox-Gastaut syndrome, also known as LGS, are severe treatment-resistant rare epilepsy syndromes. In the United States, the estimated Dravet syndrome incidence rate is about 1 in 15,000, and LGS affects 1 to 2% of patients with epilepsy. Both syndromes are characterized by seizures, developmental delay, and intellectual disability. Proper seizure management is essential to help prevent injuries and life-threatening complications, such as status epilepticus and sudden unexpected death in epilepsy or SUDEP. The 2022 International Dravet Syndrome Consensus Statement recommends the use of Onfi, Diacomit, or Fintepla as first or second line therapy. There are no consensus guidelines for LGS. Considering the seriousness of these uncommon epilepsy syndromes and the consensus statement, we ask you to consider providing Fintepla with the same access as other medications indicated for Dravet syndrome and LGS. Fintepla is approved for the treatment of seizures associated with both Dravet syndrome and LGS in patients 2 years of age and older. Fintepla's efficacy and safety in Dravet syndrome were established in 2 randomized controlled trials that both met the primary endpoint of reduction in convulsive seizures per 28 days, which was significantly greater for all included doses of Fintepla compared to placebo. Fintepla's efficacy and safety in LGS were established in a randomized controlled trial, which met its primary endpoint of reduction from baseline in monthly drop-related seizures in the Fintepla higher dose arm compared to placebo. The seizure type with the greatest median percentage change was generalized tonic-clonic seizures. Fintepla was generally well tolerated. In clinical trials of up to 3 years in duration, no patient receiving Fintepla developed valvular heart disease, VHD, or pulmonary arterial hypertension, PAH. However, Fintepla has a boxed warning for VHD and PAH due to the association between serotonergic drugs with a 5-HT2B receptor agonist activity, including fenfluramine and VHD and PAH. Echocardiograms are required before, during, and after treatment, and Fintepla is available only through a REMS program. Please refer to the PI for the full box warnings, as well as other important warnings and precautions and additional safety information. Thank you for letting us share necessary details about Fintepla. We appreciate your willingness to give Fintepla the same access as other seizure medications for Dravet syndrome and LGS. We are here to answer any questions you may have. Thank you.
Thank you very much. Any question for Pam? All right, thank you, Pam. So again, the recommendations in front of the committee are on the screen. So to retire the PA criteria for clopazim, look at making one of those agents preferred when we review an exec session. Revise the pregabalin PA for current coverage under EPSDT for fibromyalgia, and then we'll look at the cost in exec session. Discussion or questions or a motion?
Motion to approve.
Thanks, Russ.
Second.
Thank you, Pat.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Okay, thank you all.
Great. All right. Again, if you're following along on the packet posted to our website, draw your attention to page 107. We're now doing the headache prevention and treatment class update, and we'll turn it back over to Kathy Centena.
Great, thanks, Roger. So we're going to look at the current evidence for headache treatment and prevention for the following drug classes: the calcitonin gene-related peptide CGRPs, inhibitors, serotonin agonists, and the non-opioid combination analgesics. We'll also look at the literature to evaluate guidance on tension-type headaches, a diagnosis which is currently not funded under the prioritized list, but as we were just talking about, it's being reevaluated by the Health Evidence Review Commission. For that reason, we will be looking at the non-opioid combination analgesics for this purpose. And then in this review, we found quite a bit of new evidence as well: 6 new systematic reviews and meta-analyses, 6 new high-quality guidelines, 1 new formulation. Then we had 1 safety alert, and then an additional safety alert that just came about in March. So we're going to be talking to that, or speaking to that as well. So just to kind of review the current policy for the CGRP inhibitors, we do have PA on all of those products. For preventive treatment, we do require documentation of at least 4 migraines per month, failure of at least 3 FDA-approved migraine prophylactic therapies, and then a specialist consult for approval. Acute treatment is pretty streamlined. We'd ask for a triptan trial as well as address need for chronic therapy if appropriate. The preferred agents are Remunab, Fremanezumab, and Ubrogepant, and that's it for the current preferred therapies. And then for triptans, all of the triptans do have quantity limits to ensure appropriate use. Non-preferred drugs will deny on initiation, and the preferred drugs will only deny if the maximum dose is exceeded. The preferred therapies in that class are sumatriptan, niratriptan, and zolmitriptan. So utilization, there's actually a small number of claims for the CGRP inhibitors. However, they result in substantial costs, where the triptans, we do have quite a few more claims. However, they do not have a large financial impact. Just a little bit more on background, since we are covering a fair amount of drugs in this class. The triptans are just listed there. Lasmiditan is a ditan, so it's a little different. It's a 5-HT1F receptor that does not have the cardiovascular effects associated with the other triptans. Like I mentioned, we will be looking at butalbital containing products because they are indicated for TTH, as I talked about. So we will be looking at those a little bit. And then, of course, the CGRPs are listed there in the table, preventative therapies, as well as the acute therapies, differing just really in molecule size. So the injectables are larger, so they require injection, where the orals are smaller molecules, but all of them block the CGRP receptors. For preventative treatment, the guidelines do recommend that patients have 4 or more migraines per month, and then those patients should be considered for preventative therapy. We do have 3 treatments in this group that are oral: atogepant, Rimegepant, Ubrogepant are all orals, and then Zavegepant is a nasal spray, and the rest are injectables. And then just one other note, Galcanezumab is the only CGRP that's indicated for cluster headache. Looking at the systematic reviews, we do have 6. They're pretty straightforward, in which some are a little bit older, but they are included because since we're looking at TTH in this review. So the first one looks at acute treatment for migraine in children and adolescents, and it was found that triptans were more effective than placebo for the outcome of pain freedom at 2 hours, which is a really common outcome that's evaluated for migraine therapies. And I found that the triptans, again, were more effective than placebo based on moderate quality evidence. Acetaminophen was also looked at 1,000 milligram doses versus placebo for episodic TTH, and was found to be more effective than placebo. However, the lower doses were not. Cochrane looked at ibuprofen for episodic TTH as well, and found that it was more effective than placebo, again, for the pain outcome of pain freedom at 2 hours in individuals with TTH based on moderate quality evidence. The next Cochrane review was for aspirin, and it also was found to be more effective than placebo based on use of rescue medications. This is an older study, and so again, not effective, but just a different outcome than we normally see as a primary outcome, but it was found to be more effective than placebo based on low quality evidence. ARC also looked at management of primary headache in pregnancy, and they recommend acetaminophen first line. However, NSAIDs and triptans can be considered as alternative options if needed. However, all the evidence for this was low quality as well. ARC also looked at acute treatments of episodic migraines. They do recommend triptans based on high quality evidence, as well as the CGRP inhibitors based on high quality evidence. NSAIDs probably are more effective than placebo. However, the evidence isn't quite as strong. And then they also recommended that there is evidence for lasmiditan as well. So looking at the guidelines with high quality methods, we have 6 different guidelines here. The most recent one was the VA guideline that was published in 2025. They do recommend an assortment of triptans there for acute migraine, not surprisingly, as well as a combination of sumatriptan and naproxen and the nasal spray zolmitriptan. Looking at prevention, they have added 2 ARBs to the recommendations that are strongly recommended, candesartan and telmisartan. Then of course, Arenuzab, Perminezumab, and Galcanezumab were also all strongly recommended. For cluster, we only have week recommendations for any type of products. Galcanezumab is recommended weekly, as well as subcutaneous sumatriptan. And then also the nasal zolmitriptan is also weekly recommended. They don't recommend the use of opioids or butalbital-containing medications, if possible, because of the link to medication overuse headaches, which is much higher, 2-fold higher than other commonly used therapies for headache. And they also don't recommend more than 5 days of these butalbital-containing products to, again, avoid the occurrence of MOH. Looking at the next guideline is the Scottish Intercollegiate Guideline Network guideline of 2023. And for acute migraines, they also recommend triptans as treatment of choice with aspirin, acetaminophen, and ibuprofen as alternatives. For prevention, they recommend topiramate, propranolol, amitriptyline, candesartan, valproate, and botulinum toxins, all as options. And then you can see the CGRPs are also recommended, but for the people that have not benefited from appropriate trials of at least 3 of the preventative therapies I just discussed. Back in 2001, NICE had recommendations for diagnosis and management of headache. For TTH, they do recommend aspirin, acetaminophen, or NSAIDs. Acute migraine, again, triptans are the combination of NSAID and triptans. For prevention, you can see there, again, topiramate, propranolol, and amitriptyline, as other guidelines have recommended. And then cluster, they say that verapamil can also be considered. The VA guidelines actually are neither for or against verapamil, but again, cluster headache is difficult to treat, so it remains as an option. Guidelines continued. NICE had an update for atogepant, romegepant for prevention of migraine. They had the same recommendation for both, that it should be an option for patients that have at least 4 migraine days a month and they have tried and failed at least 3 preventative medications. And then lastly, the American Academy of Neurology had released or published guidelines for acute treatment in children and adolescents, and they too recommend ibuprofen, sumatriptan, zolmitriptan, rizatriptan, and almotriptan as options to treat those patients. And that was based on moderate quality evidence. We have one new formulation, and it's a combination product, Symbravo. It combines the NSAID meloxicam with the triptan rizatriptan. This is a tablet in which they can take 1 tablet as needed, but not to exceed more than 1 tablet at onset of migraine. Treatment of more than 7 headache days per month is unknown at this time, and so not recommended. This product is a little different in that it uses a different delivery system called Mosaic for the meloxicam portion. This is proposed to have a quicker onset of action. The approval was based on 2 double-blind controlled studies comparing the combination product to placebo. The demographics were mostly female. However, this population group is more likely to get migraines as well. And their most bothersome symptom was most commonly photophobia. And so both trials looked at a co-primary endpoint of pain freedom at 2 hours, and then the most bothersome symptom-free at 2 hours. The first trial treated moderate to severe intensity of migraines, where the second trial was in mild migraine, to be started at first symptoms of mild migraine. You can see in trial 1 that the combination product was superior to placebo for those endpoints, and in trial 2 as well, both statistically significant. There is a box warning for the risk of cardiovascular thrombotic events due to meloxicam, as well as contraindicated in CABG surgery and increased risk of GI bleeding due to meloxicam as well. A couple new safety updates for atogepant. In April of 2023, they updated the labeling with warnings and precautions of serious hypersensitivity reactions such as anaphylaxis and angioedema. And then, as I mentioned just recently in March of 2025, for the whole CGRP class, they added the warning of new onset or worsening of pre-existing hypertension or new onset or worsening of pre-existing Raynaud's phenomenon. So now I'd like to go over just some brief recommendations to update the criteria. For this first slide doesn't have any changes, but I just wanted to remind everyone that it applies to all CGRP inhibitors. And this does start at page 135 in your packet if you'd like to follow along. Number 1 through 7, a kind of standard wording. And so we're going to go ahead and skip here to number 8. And we're talking about preventative treatments. And again, just as a reminder, we ask that there's documentation that the patient has experienced 4 or more migraine days in the previous month, and the patient is at least 18 years old or an adult. And if so, we go to number 9, and what we're just recommending here, that the 2 therapies, candesartan and telmisartan, be added as options before moving on to CGRP. In number 10, this specifically calls out erenumab and hypertension, because before that March warning, that was the only CGRP in the class that specifically carried that warning. But now that it applies to the whole class, the recommendation is to actually remove that warning and not call out erenumab specifically. Moving to the next slide, there are no changes for the acute treatment, so we'll go down to number 15, in which this applies to cluster headache patients, and we're just asking that the patient has an adequate trial of 2 to 6 months or a contradiction to at least 2 of the following therapies. So kind of updated that list to include verapamil and the steroid injections. I think we could also add to this list the sumatriptan subcutaneous injections or zolmitriptan nasal spray. This is only a week recommendation, but again, we don't have really good evidence for any of the cluster headache treatments. So I would recommend that as well. And then I'm looking at the renewal criteria. There's no changes really. In number 7, the wording has just been updated to align with the Botox criteria, but and try to make it clarify it a little bit, but no real difference in wording there or meaning. I'll let you go ahead and look at that. Then moving on to the serotonin agonist, the next slide. No changes to this slide, just if you want to follow along, this criteria starts at page 139. And looking at the table, the only change is to add that combination product with the quantity limits of 7 tablets a month as recommended in labeling. We can go through the whole criteria, but I didn't include it in the slide presentation as there's no changes. So we can revisit that if need be. Looking at butalbital, this criteria is all new, so we'll go through it a little bit more together. Again, because of the risk of dependence and medication overuse headache, we are recommending criteria for butalbital containing products. You can see there in the table, we're recommending quantity limits of 6 capsules or tablets per day, and then not more than 30 capsules in 30 days, capsules or tablets. And again, most of this is based on labeling or guideline recommendations. And then standard wording number 1, ask if the patient has migraine headaches. If yes, we actually deny because none of the migraine guidelines recommend butalbital products. Going to number 3, ensuring that the patient does not have medication overuse headaches. So if no, going to number 4, asking that they have a diagnosis of tension headache and for which butalbital products are indicated. If yes, go to number 5 and just ask that they've had a trial, at least 2 of the following drugs that are recommended more first line by guidelines. If they have and they're still requesting, we're asked that it can be approved for up to 6 months and that the quantities not be exceeded as outlined in the table. So the recommendations for this class are no changes to the PDL based on the evidence. We do recommend updating the criteria for CGRPs and the serotonin agonist just for those clerical updates and the new drug additions, as well as to recommend the PA criteria for butalbital containing products. And I would add more specifically, I guess, for the CGRPs, recommending that we delete number 10, the hypertension call out for Renumab, and then also consider adding the 2 triptans for number 15 for cluster headache. Any questions? I know we have comment as well.
Nice job, Kathy. Any questions for Kathy on the information she presented or the proposed changes to the criteria? Okay, hearing none, we do have 3 representatives from manufacturers that have signed up for public comment. Jay Mehta, I don't know if I said your name correctly, Mehta, from Axum Therapeutics, manufacturer Symbravo. Are you able to unmute your line?
Yes, good afternoon. Can you hear me?
Hear you loud and clear. The floor is yours.
All right, perfect. Well, let me go on video. That works. Actually, the video is not working, so that's okay. All right, thank you very much. So again, my name is Jay Mehta, Health Outcomes Liaison at Axum Therapeutics. Thank you for the opportunity to provide information on Symbravo, a recently approved novel oral single-dose medicine approved for the acute treatment of migraine with or without or in adults. As Catherine eloquently has already stated, Symbravo represents a multi-mechanistic approach to treating a migraine that targets multiple pathways underlying the symptoms of a migraine attack. Symbravo consists of MoSEIC meloxicam and rizatriptan. MoSEIC stands for Molecular Solubility Enhanced Inclusion Complex, which is Axum's patented rapid absorption technology. The MoSEIC formulation results in approximately a 5 times faster median time to max plasma concentration for meloxicam, while maintaining a long plasma half-life. Meloxicam is a COX-1, COX-2 inhibitor, non-steroidal anti-inflammatory drug with preferential binding to COX-2, and rizatriptan is a 5-HT1B1D agonist. In the pivotal phase 3 Momentum trial, a single oral dose of Symbravo provided rapid freedom for migraine pain and most bothersome symptom at 2 hours post-dose, as well as return to normal functioning at 2 hours, and sustained pain freedom through 24 hours. In addition, 85% and 77% of patients treated with a single dose of Symbravo did not use migraine rescue medication within 24 hours in the Intercept and Momentum trials, respectively. Symbravo demonstrated efficacy across a broad range of migraine severity, mild, moderate, and severe, and in a head-to-head evaluation with its components, MoSEIC, meloxicam, and rizatriptan. Of note, the FDA-approved labeling of Symbravo states it's not substitutable with other formulations of meloxicam or rizatriptan, even if the milligram doses are the same or similar. The most common adverse reactions in the controlled studies were somnolence and dizziness, being reported each in 2% and 1% of patients in the Symbravo and placebo arms, respectively. As with all prescription NSAIDs, Symbravo carries a box warning for risk of serious cardiovascular and GI events. Please refer to the full prescribing information for a complete list of warnings and precautions and adverse events. In summary, Symbravo is a novel oral multi-mechanistic migraine treatment that addresses important clinical unmet needs, should be considered for preferred status on the PDL for the Medicaid beneficiaries in the state of Oregon. Thank you for your consideration. Happy to address questions. Also, one thing to note, I did see there was a quantity limit of 7 tablets per month, and I know that there's some language in the PI around what was typically used on a monthly basis in the trials. However, the bottle size is nine tablets, and that is what is recommended by Axsome. Thank you very much.
Appreciate the clarification and your information. Any questions from the committee for Jay? Okay. Appreciate your time. Aaron Nowak from AbbVie, are you able to unmute your line?
I am. Can you hear me?
Hear you loud and clear. The
Great.
floor is yours.
Thank you. Hi, everybody. My name is Erin Novak, Medical Outcomes and Science Liaison with AbbVie. I'll be speaking on atogepant, brand name Qulipta. This is a CGRP antagonist for migraine prevention. Kathy, thanks for addressing the safety label updates to the committee. More safety information as well as efficacy information, in addition to what I shared today, can be found in the prescribing information at arxabbvie.com. Now, I recognize this is not a new therapy, but I'm here to provide some unique characteristics of atogepant as well as some updated information with the purpose of supporting 2 requests today. Number 1, to add Qulipta to the Oregon PDL, and then 2, to consider reducing the prerequisite requirements. To start, the unique characteristics of atogepant are as follows. Number 1, this is the only oral CGRP therapy covering both episodic and chronic migraine. It offers a mode of delivery that is often preferred by patients. 2, it has a shorter half-life versus the monoclonal antibodies, allowing for fast clearance of the drug within a few days shall a patient need to withdraw therapy. Number 3, there are multiple dosing options that exist for episodic migraine, allowing flexibility for efficacy, tolerability, as well as dose modifications. And 4th, health outcomes data on indirect comparisons have demonstrated that atogepant has the lowest number needed to treat within this class, potentially resulting in cost savings. So collectively, atogepant is offering a beneficial treatment option for patients and providers, as well as for the state. Next, I'd like to share an update from the American Headache Society, or AHS. And in March of 2024, they published an update to their consensus position, and that stated that CGRP targeting therapies should be considered a first-line treatment option for migraine prevention, along with other previously recommended first-line treatments, but without a requirement for prior failure of other classes, given the substantial evidence for efficacy, safety, and tolerability. Alongside that, I'd like to share some Truven Health market scan retrospective claims data. And what this indicated is that adult patients with chronic migraine, persistence to commonly prescribed preventive migraine treatments is really suboptimal. And those that initiated an oral migraine preventive medication like a TCA, a beta blocker, SNRI, or anticonvulsant, that 75% had discontinued therapy at 6 months, while 86% of patients had discontinued at 1 year. So to summarize these 2 points, considering the high discontinuation rates of traditional oral preventive medications for migraine, the current 3-step requirement for CGRP preventive treatments may not be effectively achieving the goal of having patients manage their migraines with the more traditional options. Thus, it's respectfully requested to reduce the prerequisite requirements, which could help align to the evolving consensus on migraine management. Thank you for your consideration, and I'm available for any questions that you might have on this. Thank you.
Appreciate that, Aaron. Any questions from the committee for Aaron? All right, thank you for your time. Next, we have Rochelle Yang from Teva. Teva?
Yep. Teva.
Okay, I got it right the first time.
Either one. Hi, my name's Rochelle Yang with Medical Affairs at Teva. I have a specific comment regarding question 9 of the CGRPP criteria, and that would be the requirement for the use of 3 generic oral drug classes for prevention prior to the use of CGRPs, which effectively makes CGRPs the 4th line. And I won't repeat what Aaron, the previous speaker, had very eloquently stated around the AHS consensus statement that was put out last year. I will just add that this replaced their consensus statement back in 2021 on the same topic, where they had recommended CGRPs after in trial and failure of at least 2 traditional drug classes. But based on this updated AHS statement, we have seen a number of state Medicaids across the country respond in the past year by removing their oral generic drug class requirements entirely for the CGRPs, such as Texas, Arkansas, New Hampshire, and Iowa. And we have also seen some states reduce their step therapy requirements from 2 steps down to 1 drug class, such as Pennsylvania and Indiana. And just kind of looking across the state Medicaids here in the region, we do see Washington, Alaska, Montana, and Wyoming require a trial and failure of 2 generic drug classes. Idaho and California actually do not have step therapy or PA requirements for formulary preferred CGRP agents. So the 3-step requirement for Oregon is somewhat of an outlier in the region. And per AHS, there is evidence that delaying effective preventive therapy may result in migraine disorder becoming more refractory. So based on the above, I would just ask the committee if you could potentially consider removal of the 3-step trial and failure requirement for the CGRPs, or perhaps a reduction down to 1 or 2 oral generic drug classes as step therapy. Thank you.
Thank you, Rochelle. Any questions from the committee for Rochelle?
And I would like to add, Roger, that we did look at the AHS guidelines, and actually it's just a consensus statement, and it was excluded for lack of rigor.
Thank you. So the committee, any questions for any of our speakers or for Kathy? We'll bring the recommendations back up.
Kathy, this is Eddie. Could you remind us again the rationale for the 7-day limitation on the combo drug?
Sure, yeah, so that's what was recommended in labeling, is that they hadn't studied more than 7 days of therapy. So it was just unknown. So that's why that's what was added to the criteria. We can revisit that. Because
I see on their label it talks about limiting use to less than 10 per day, which is maybe the rationale for why the package size is 9.
Okay, yeah, the most recent labeling I saw was 7, but I think that 10 is appropriate as well, considering the drugs in the combination treatment.
I'm just wondering what other folks think about updating that to align. It would be a bit of a headache, I think, for some pharmacies to have to hold on to 2 tabs.
So again, I'm hearing you asked that the recommendation for the quantity be up to 9, the package size.
Right.
I think that certainly sounds reasonable, but defer to the other committee as well.
No objection to that.
All right. Thank you for that, Eddie.
Yeah, thank you. I'll change that then to 9. Okay.
And with that, the other recommendations. Any more questions or observations, recommendations, or motion to approve as amended?
Doug Carr, motion to approve as recommended, with the addition of the increase of 7 to 9 on the particular drug.
Thank you, Doug.
I'll second.
Thank you, Eddie.
All those in favor?
Aye.
Aye.
Aye. Anyone opposed?
Aye.
Abstain? Okay, thank you all.
Great. We are almost right back on schedule. We are slated to take a 15-minute break. So with that, I'm going to share my screen. If I can get the right window here. And we'll be back, reconvene in 15 minutes and continue with our last couple topics and then executive session. So thank you very much. All right, I hope everybody had sufficient time on the break to take care of whatever was needed. We have 2 more topics before we go into executive session. So for those in the audience who are following along with the packet of materials, direct your attention to page 145, and we'll turn it over to Sarah Servin.
Thank you. And I'm going to talk today about drugs for hyperhidrosis, which is currently an unfunded condition on the prioritized list of health services. So this is another class that we're looking at to develop some specific criteria for our EPSDT population that'll be implemented currently, and then with consideration of what will happen in 2 years when the prioritized list changes. So just as some background, we're mostly going to be focused on primary focal hyperhidrosis, which is diagnosed based on excessive sweating for at least 6 months without an underlying cause, and that's where the primary comes in. There are a lot of secondary hyperhidrosis diagnosis, a lot of conditions out there that can cause sweating, and so primary hyperhidrosis diagnosis does kind of involve ruling out those underlying causes. The diagnosis also includes at least 2 of the following characteristics, including bilateral presentation, it being bad enough to impair activities of daily living, frequency of more than once per week, onset at less than 25 years, positive family history, and excessive sweating that doesn't occur during sleep. There are some drugs that are FDA approved specifically for primary axial hyperhidrosis, so underarm sweat. It's the most common type of hyperhidrosis, although it can also occur on the palms, on the feet, and on the face. But these drugs are approved for axillary hyperhidrosis, and they're glycopyrronium and sofpironium, which are topicals that you apply daily, and then onabotulinum toxin A, which is an injection given in the underarm one time, and then you repeat it as needed when symptoms reoccur. And in clinical trials, symptoms were controlled for a median duration of about 7 months. Non-pharmacologic treatment options include lifestyle modifications, avoidance of triggers such as spicy food that may make sweating worse, and then modification of clothing, so wearing clothing that is cooler and will decrease sweating. Additionally, there are prescription antiperspirants out there, such as aluminum chloride, that are commonly used, and then some other non-pharmacologic treatment options that are kind of reserved for typically more refractory cases when other treatments don't work. When we evaluated literature, I did identify 2 systematic reviews that I included in the evidence write-up. The first looked at treatments for primary hyperhidrosis and was published in 2020. This review included both randomized controlled trials and non-randomized studies, and identified a whole host of studies for multiple different interventions. But they really identified only moderate quality evidence for symptom improvement with botulinum toxin in axillary hyperhidrosis over the short duration of about 16 weeks, and said that there was low or very low quality evidence for all the other interventions that they identified, and those were mostly oral anticholinergics and some of those non-pharmacologic interventions that I previously identified. There was insufficient evidence to evaluate relative efficacy and safety of these interventions. Most of these studies were either non-controlled studies or compared the intervention to placebo. The second systematic review looked at botulinum toxin for both primary and secondary hyperhidrosis. They included 8 randomized controlled trials in the review, 6 of which evaluated primary axillary hyperhidrosis and came to pretty similar conclusions as that first review. They said there was moderate quality evidence that botulinum toxin improves symptom severity and quality of life over the short term, 2 to 8 weeks is what they looked at compared to placebo. Our literature search didn't identify any high quality systematic reviews that evaluated those topical anticholinergics. They are a little bit newer to market than botulinum toxin, and I didn't identify any recently published high quality guidelines. And so I did take a look at randomized controlled trials for these drugs. There are 3 phase 3 trials for both sofpironium and glycopironium that are included in the write-up, and then 2 for onabotulinum toxin A. These trials mostly looked at primary axillary hyperhidrosis in people with severe symptoms, and they did evaluate symptom severity using a variety of different scales. People in the trials had a gravimetric weight of sweat of greater than 50 grams per arm, and had symptoms for greater than 6 months. So kind of getting to that diagnosis of primary axillary hyperhidrosis. And they did exclude people who had secondary hyperhidrosis. And by and large, these drug treatments did improve symptoms and disease severity compared to placebo. The largest treatment effect was seen with onabotulinum toxin A, with a treatment difference from placebo of about 50%. A little bit lower difference from placebo in the other drugs, 17 to 18% with the sofpironium and 25 to 39% with the glycopironium. And the quality of evidence was rated as low for the sofpironium because those studies to date are unpublished, whereas others are published in peer-reviewed journal articles. In general, the topical anticholinergics were associated with dermatologic adverse reactions, such as dermatitis, itching, redness, application site pain, and then some systemic anticholinergic side effects as well, including blurred vision and dry mouth. And so there are warnings and precautions for both of these drugs for some of the conditions that you would normally see for other oral anticholinergics, including things like urinary retention, body temperature control, and blurred vision. For onabotulinum toxin A, the most common adverse effects were injection site pain and bleeding, and then compensatory non-axillary sweating, so sweating in other areas of the body. The botulinum toxin does have warnings for serious adverse reactions associated with unapproved uses, distant spread of toxin effects, swallowing and breathing difficulties, concomitant neuromuscular disorders, and transmission of viral diseases. Not all of these were observed in the clinical trials for hyperhidrosis. Botulinum toxin is approved for a variety of different indications, but they are included in the labeling for the drug. So the major gaps in evidence for these drugs, there's really not a whole lot of evidence for non-axillary hyperhidrosis, so sweating of the palms, feet, or face. Those are some of the most common other types of hyperhidrosis. There are some small studies of botulinum toxin in palmar hyperhidrosis, but really limited by small, populations included, lack of comparators, and lack of well-reported methods for those studies. We also don't have data in secondary hyperhidrosis in patients with more mild symptoms. And then there isn't really any direct comparative efficacy or safety data for drug treatments. And then also there's no studies evaluating combination drug therapy. So one of the topicals plus botulinum toxin, for example. So our recommendations are to implement prior authorization criteria for both the topical anticholinergics and onabotulinum toxin A to limit use to people who have a diagnosis of primary axillary hyperhidrosis, people with severe symptoms when prescribed with the dermatologist, and when they have treatments failed to respond to some of the non-pharmacologic lifestyle management. And the recommendation would be to implement similar criteria for both topical anticholinergics and onabotulinum toxin A, but to make onabotulinum toxin A a preferred treatment option for hyperhidrosis, just because it's had the largest treatment effect size and a relatively long duration of effect. So one injection lasts about 7 months compared to applying an anticholinergic daily, and then to make the topical anticholinergics non-preferred. And so here are the PA criteria for the topical anticholinergics. I included a table just referencing the indication and FDA approved age for the drugs. We'd basically be asking whether it's a funded condition, and then anyone eligible for EPSDT review currently would go on to the other clinical criteria. If not eligible for EPSDT review, then it would be denied in question 3 for funding. And then come 2027, we'd remove this question 3, and this same basic medical necessity criteria and medical appropriateness criteria would apply to everyone. And so these are the clinical criteria that we're proposing. Questions 4 and 5 are documenting medical necessity based on impacts of quality of life, other conditions, and disease severity. So question 4 mirrors our language in the OAR's Oregon rules for how we define medical necessity for a condition. And then question 5 asks for documentation of disease severity based on the scales that were used in clinical trials, and some of those are outlined here. Question 6 just asks for FDA-approved age and indication, specifically because secondary hyperhidrosis is not FDA-approved and non-axillary hyperhidrosis is not FDA-approved. Question 7 asks whether it's prescribed by or in consultation with the dermatologist. And then question 8 asks about those non-pharmacologic lifestyle managements and gives some examples here, although there could be others, but things such as trigger identification and avoidance, clothing modification if possible, and use of topical antiperspirants. And then for the topical anticholinergics, we'd ask that they try our preferred product, which would be botulinum toxin, or have contraindication intolerance to that. And then if the request was for botulinum toxin, it would just be approved for 3 months. And then as far as renewal, we just ask for documentation of symptom improvement from baseline, and then they could get a longer approval. And again, this same basic criteria we're recommending to add to the botulinum toxin criteria for hyperhidrosis. And I'd be happy to take questions if folks have them.
Good job, Sarah. Questions on the information presented or recommendations? We do not have anybody signed up for public comment. All right, thorough presentation. So the recommendations are in front of you. Don't need to recite them. So we'll entertain a motion to approve.
Motion to approve as recommended.
Thank you, Eddie.
You have a second?
Second.
Thank you, Pat.
All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? Okay, thank you.
Great. All right. The final topic that we're presenting today starts on page 164 if you're following the packet of materials, Botox class update. And Sarah Fletcher, the floor is yours.
Thanks, Roger. Yes, the last class we're looking at today is the botulinum toxins, and this is a class update from the previous 2023 review. And I'm going to be looking at evidence since the previous update on existing indications, because there are quite a few for Botox, and those are listed on page 167 in the packet. I'm going to include the evidence for migraine as it relates specifically to Botox. We're going to review and evaluate evidence for chronic anal fissures, which it's not been used for previously in Oregon Health Plan. And then you just saw the evidence for hyperhidrosis, so that was already reviewed. Go to the next slide. I'm going to go over the evidence for the existing indications before I go to the anal fissures. But first, I included an updated Cochrane review that was primarily in children for the treatment of strabismus, which is crossed eyes or misalignment of the eyes. It was mostly in children, as I said, and the quality of evidence was pretty low certainty because of the size, but it found that surgery was more likely to improve or correct strabismus than botulinum toxin, and that retreatment of acquired or infantile estropia, which is an inward turning type of strabismus, that botulinum toxin would have little to no effect when compared to surgery for retreatment in patients who'd already had surgery. And that was for both sensory fusion and stereopsis, which is depth perception. If you go to the next slide, I also included one guideline, which was for the treatment of headache. And I think Kathy has already gone over this, but the specific treatments as they relate to Botox are for the prevention of headaches, which was a weak recommendation for, and then use for episodic migraines and chronic migraines where there's a weak recommendation against. And those were in the previous iteration of this guideline as well and have not been changed. The only new recommendation is that there's insufficient evidence to recommend any specific treatment for or against prevention of migraine, for tension headaches, or for cluster. And that was a strength of evidence neither for nor against. So it's just insufficient evidence. And if you go to the next slide, we'll move into anal fissures. Currently, they're on line 519 of the Oregon Prioritized List, which is not a funded line. However, prior to the 2027, HERC is actually looking at adding surgical coverage, and that should happen, or they're looking at it currently. And we may anticipate a guideline note which would allow for medical treatment. So most common anal fissures themselves are the most common cause of rectal bleeding, and they can be extremely painful. Patients talk about it like they're being cut by glass. And there's about 11% lifetime incidence, but in the acute phase, these can heal spontaneously, especially when using conservative therapy like dietary changes, laxatives, sitz baths, and then you can use topical lidocaine and steroids for things like pain relief. There is medical therapy, which is an option, such as topical nitroglycerin, and then there's topical calcium channel blocker products, but those are not commercially available in the US. After about 6 weeks, you start to get some chronic changes in the fissures themselves, and they can display different characteristics. And while they can still heal spontaneously, it's less likely to occur. And some additional treatments that you could add to what was already listed can include botulinum toxin or surgical interventions. Now, I included one systematic review of botulinum toxin versus topical nitrates from 2018. This particular review had a lot of heterogeneity as far as dosing, length of treatment, length of follow-up. They used Botox doses of 20, 30, 40, 70 units. They had different dosing for different nitrate products. But the findings were that the incomplete fissure healing rate was lower for botulinum toxin, but it was not a statistically significant difference. And there was significant heterogeneity specifically with that outcome because of all of the differences amongst the included trials. The rate of transient anal incontinence was higher for botulinum toxin, but again, not quite statistically significant. And then fissure recurrence was similar, about 18% versus 25%. And there's different definitions of how that was measured between the different studies. And then overall, the side effects were more common with topical nitrates, about 6% versus 33%, but that was primarily driven by headache, which is a known side effect of nitrates. We go to the next slide. There was one high quality guideline for this indication that I found, and it was from the American Society of Colon and Rectal Surgeons, and it was published in 2023. As far as acute fissures, they recommended that non-operative treatment is safe and should be typically first line. Those non-operative treatments are what I mentioned earlier as far as fiber, sitz baths, that type of thing. And then if you go to the next slide, the treatment of chronic fissures, I have a bigger table in the packet itself, but this is the distilled recommendations as far as the medical therapies. So anal fissures can be treated with topical nitrates first line, and that's a strong recommendation based off moderate quality evidence. Also, topical calcium channel blockers have similar efficacy and fewer side effects. So they're also recommended first line. Unfortunately, they're not available commercially in the US. And then botulinum toxin has been found to have similar results compared to those topical therapies as both first-line therapy or as a second-line therapy to have modest rates of healing improvement. And that was also a quality of evidence moderate. And then as far as repeat treatment, lateral internal sphincterotomy, which is a type of surgery, or botulinum can be used for recurrent fissures, but there's really not much data. And so that's a very weak recommendation. If you go to the next slide, I also included 2 small trials that I came across because they did have comparative data and they were using combinations. The one on the left it was a single study in Spain, or single center in Spain, and it was botulinum toxin combined with either placebo or topical diltiazem. And only had 70 patients who had had a chronic anal fissure for about 8 weeks, and they treated them for 12 weeks. The fissure healing rates for the intent to treat population was pretty similar at 37% versus 41%. When you looked at the per protocol population, it was higher in the combination group, but that group had more dropouts, and it was a very small population overall. On the right for the Hussein study, that was a single center in Pakistan, and it was also a botulinum toxin alone or with a topical nitrate, but there was no placebo group, and this was open labeled. It had 88 patients in it, and they'd had chronic anal fissures for only about 4 weeks or a recurrent fissure, and they were treated for about 4 weeks. And the fissure healing rate on that study, because it was measured at different times and defined in different ways, was about 70% versus 90% in favor of the combination. So the 90% was the combination group. And now if we move to the next slide, there were a few new indications in this group. Daxxify had the addition of cervical dystonia, which many of these products have this indication. And then Xeomin and Botox both had the addition of some cosmetic indications, and cosmetic indications are not covered by the Oregon Health Plan. And then for FDA safety alerts, back in 2024, there were multiple counterfeit versions that were being found in licensed and unlicensed medical facilities being given for cosmetic uses that were causing significant side effects and morbidity. And so the FDA put out an alert about that. And then there were some warning and precaution updates and PIs that were mostly clerical. Xeomin had a new subsection added for a risk of using it at a site where there was already atrophy or weakness. Several of the other PIs already included this. And then Diasport just had kind of a reorganization so that that same recommendation got moved to a different subsection. If you go to the next slide, we're going to pull up a packet in a second and just go through the Botox PA criteria, but I wanted to just summarize the changes. First is the addition of the hyperhidrosis language, which is alignment with the other criteria and was just voted on. So it's, unless there are other changes that you want after you see it, that's not what we're looking at as far as wanting to change from IREX. And then I have the addition of candesartan and telmisartan as options for chronic migraine, and that's also alignment with what was presented earlier during the headache section. And then lastly, I wanted to add the use of chronic anal fissures that were lasting longer than 6 weeks. And I just wanted to give the high level rationale for why we're not requiring a step therapy and only just requiring that it be for 6 weeks. And that's partly because it would only be given by a specialist. And by the time a patient had made it into a specialist who would do this, conservative therapy would have been tried, or it would be unlikely to work because of the time that had elapsed already. The efficacy between the topical agents and the botulinum toxin seems to be pretty similar, and the guidelines do recommend it as a first-line options, and the costs are actually pretty similar as well. And if you treat with medical therapy earlier in the course of treatment, you might be able to not have the need for surgery later, because the longer these symptoms duration lasts, the more risk of surgery. So we can switch to the packet. So you can see the addition for hyperhidrosis on the first page. And then question 6 is the update to align with the headache criteria that was presented in the headache section. Question 8 had a couple typos. Question 10 is the addition for botulinum toxin for chronic anal fissure that's lasted longer than 6 weeks. And the 6 weeks definition was pulled from that guideline. And then 11, 12, 13, 14, and then 15 on the next page are the hyperhidrosis criteria as presented by Sarah in the previous section. I think that's pretty much it. A couple little additions at the bottom because of the hyperhidrosis, but Have any
Good job, Sarah.
questions? Mhm.
Questions for Sarah?
We can switch back over to the Rex if you want.
We do not have any public comment. So again, questions about the information that was presented or the criteria that was in front of you now?
So our recommendation is for no general policy updates for the existing indications. And I have migraine there because it's a clerical edit based off of what we've already voted on, but no new evidence related to Botox. And then to update the PA criteria to incorporate botulinum toxin. And that's in anticipation of a guideline note that would allow treatment. And then we'd like to evaluate the costs of the different agents in executive session.
Do we hear a motion to approve?
Motion approved.
Thank you, Pat.
We have a second?
Doug Carr, second.
Thank you, Doug. All those in favor?
Hi.
Aye.
Anyone opposed? Abstain? Okay, thank you.
All right, that concludes the order of business. We now need to meet in executive session. I need to put on my best radio voice and read a blurb for everybody. We'll go to a breakout room. No decisions will be made in that space. We'll then convene back here to take final recommendations. So the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to RS 1926602F and ORS 44356 and 2, which allows the P&T committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class. It's necessary for the committee to make final recommendations or to comply with the requirements of ORS 44353. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session except to state the general nature of the session as previously announced. No decisions may be made in executive session, and at the end of the executive session, we will return to open session. How'd I do, Pat?
I mean, that's certainly top 5th percentile for you, Roger.
Right, that might be top 5. All right, well, we're going to put everybody in a breakout room, and we'll be back, shortly. All right, we are returning from executive session. Give us just a minute for everyone to get settled back on this side. Do a head count and make sure if committee members can take themselves off mute.
Yep.
Getting myself settled as well. The recording is back on. And Samara, I think we'll call upon you in a minute. Yep, perfect. Russ and Kat. Bridget, Pat. Okay, we only had a few classes to go through, so I'm going to lump the final recommendations. Let's see. I'm hearing people say they're unable to unmute, so hold on a second here, Jeannie.
She's on the phone.
Well, I think she lost her co-host permission because of that, so let me rectify that. Thank you for calling that out.
Ah, there you go. You got me now. I seem to have trouble with the portals today. Thank you.
All right. That's enough said. Okay. So we've reviewed pricing in executive session. I'm going to lump these recommendations together. So we had the drugs for weight loss, weight management with the PA update for the OSA. So the recommendation is to make Zepbound version of tirzepatide preferred. and subject to the PA criteria, and that's pending the acceptance of the supplemental rebate offer for that obstructive sleep apnea. For the anti-epileptics and the non-injectable anti-epileptics, the recommendation are to make generic clobazam tablets and oral suspension preferred, make pregabalin capsules and generic levetiracetam extended release 24-hour tablets preferred, and to make carbamazepine oral suspension non-preferred. For the headache prevention and treatment class, the recommendation is to make the rizatriptan tablets and rapid tabs and the elatriptan tablets all preferred. And finally, in the Botox toxins class update, the recommendation is to remove PDL status for all the products. Is there any discussion? And if not, we'd entertain a motion to approve those PDL changes.
Doug Carr, motion to approve.
Thank you, Doug.
Second.
Thank you, Bridget.
All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? Okay, thank you all.
Fantastic. Well, that concludes our April P&T meeting. Thank you very much. The next P&T meeting is scheduled for June 5th. The draft documents are going to actually be posted on April 15th. So get the good with the bad. You can look at our drafts and file your taxes. So anyway, look forward to your feedback on those draft documents. And again, really appreciate the committee's volunteering for this really important work. And with that, the P&T meeting concludes. Samara, great job today. Thank you.
Thank you, Roger.
Thank you.
Thank you.
Thank you all. Take good care.
Thank you, everybody.